Hey guys, how are you guys doing? Welcome to another topic discussion video. And in this video today we'll be discussing Lisfranc injury and treatment plan. So this is a presentation that I just gave to my externship for July month, and I think it went pretty well. So I wanted to share this with you guys and kind of give you guys an idea of how extern presentation kind of goes. The presentation today that will involve anatomy and risk factor, associated clinical risk factor, and treatment plans. And as some of you guys may know, Lisfranc joint complex is basically a joint complex at the metatarsal base and the cuneiform bones and the cuboid. It is lined by about 6 to 8 bands of dorsal ligaments that kind of goes in kind of all direction, longitudinal, transverse, or oblique fashion. But one thing to keep in mind is there is no dorsal ligament between the metatarsal 1 and metatarsal 2. For the interosseous ligament, there are about a little bit more than 5 interosseous ligament, and the Lisfranc ligament that people often refer to as is part of the Lisfranc ligament. Is a type of interosseous ligament, and it is about 8 to 10 millimeters long and about 5 to 6 millimeters thick, and it starts from the lateral margin of the medial cuneiform to the medial side of the second metatarsal, and sometimes it even goes along to the third medial side of the base of third metatarsal. And it extends distally, laterally, and plantarly, and as it goes plantarly, you will come across a ligament between the medial and the intermediate cuneiform, and kind of attaches there, and sometimes even to a peroneus longus tendon. The important to note in the Lisfranc joint complex is, as you can see in the picture, that I'll put it up over here, is you could, on the right side of the picture, you can note the 3 numbers, 1, 2, and 3, indicating 3 different compartments in the Lisfranc joint complex. Medial for 1, central for 2, and 3 for lateral. And sometimes even more recent classification of Lisfranc joint complex revolves around the medial column, lateral column, and the central column. And it's important to note that these capsular compartments, are not connected to each other, which makes it a little bit more tricky when you're trying to fix this Lisfranc joint complex issue. And also you can note that the second metatarsal, which is often referred to as the base, which is often referred to as the cornerstone or the keystone of the metatarsal kind of arch, is wedged between the 2 cuneiform, medial and the lateral cuneiform, and creating that Lisfranc joint motif, just like an ankle motif in a way. So keep this in your mind when we talk about kind of the treatment plans that revolve around it, because it's basically most of the Lisfranc joint ligament injury revolves around reducing the dislocation and fracture, and you have to take consideration of the soft tissue, which are the ligaments I just mentioned. There's a study done that was published in JBJS where they looked at just varying factor of Lisfranc injury, and they're trying to determine if there was any significant predictors for Lisfranc fracture or dislocation. And what they found out is the medial motifs of the Lisfranc joint, as illustrated in the diagram here over as A, is a significant predictor of Lisfranc injury. And the author wanted to say that you want to have somewhat of a depth, like a longer depth, rather than a shallower one, because if you have a shallow depth, that means that you want to have a smaller attachment of Lisfranc ligament, which means that you're going to have a weaker one essentially, and it will be a little bit more unstable compared to the other control group. So they said that for the in a cadaveric study, they found that the medial mortise tended to be 11.61 millimeters, while the patient with Lisfranc injury generally had about 9 millimeters in depth. So that was kind of interesting. So let's now talk about how we could actually kind of evaluate Lisfranc injury. And oftentimes patients come into an ER in office with a foot pain. You're going to take an x-ray first. And if you suspect some sort of a Lisfranc joint complex problem going on, then you will order an MRI, or the ER will get an MRI. And what you can notice on the picture over here is with a straight, annotated by the straight arrow, is the high intensity surrounding the Lisfranc ligament, which indicates inflammation and somewhat of an injury. And Rakin from Jefferson Hospital, basically here in Philly, did a study where he kind of see if an MRI can be used to predict basically unstable or stable Lisfranc injury, and compare that to the result of intraoperative finding through the stress test. And out of the 21 cases, 90% of the cases they were able to predict it, which is fairly high, and ultimately came up with a number that MRI is 94% sensitive and 75% specific and 94% positive predictor value for the Lisfranc injury. And one key thing that I want to mention is that the researcher also stated that the plantar ligament that goes from the intermediate cuneiform, or C2, from the second metatarsal was oftentimes injured, about 17 out of 21 cases. But the author noted that this is a distractor ligament, so you should still focus your treatment planning based on the Lisfranc ligament injury. How you could injure your Lisfranc, there's two general ways: direct force and an indirect force. And direct force is basically a kind of trauma where you drop something heavy on it and basically collapse the arch, and in that process tear the Lisfranc ligament, because remember, it's on the plantar surface. A more common way is indirect method, where patient is hyperplanar flexing his or her foot, and basically grand reaction force coming across, as illustrated on the picture on the right. And oftentimes patients complain of missing a step on a curve, or playing certain sports activity, or even in a motor vehicle accident where the foot is stuck in the brake paddle in that position. And as you guys know, the classical classification is Kwanoo and Quask in the 1909, and Hardcastle came about and kind of talked more about like where the dislocations occurring within the foot in the 1982, and then the Meyerson modification of the Hardcastle brought the B1 subtype of B1 and B2 and C1 and C2. And basically there is total incongruity, partial incongruity, and divergent as a general classification. So now I'll talk about kind of the treatment plans, and one of the earlier methods that people reduced Lisfranc joint injury was by casting. There was a study done that illustrated that casting for 4 weeks did not really fare well. In terms of the results, 7 out of 15 cases had residual pain, while 6 out of 15 cases had longitudinal flattening of the arch, kind of sequela. And they measured that by looking at the medial cuneiform at the inferior edge and at the base of the fifth metatarsal on the lateral view. And generally, medial cuneiform is higher, which means that the difference between those two bones are kind of in a positive value, about 1.5 millimeters. But as there is a weakness in the Lisfranc ligament, which kind of creates that arch, will decrease, and the weakness can be illustrated by that medial cuneiform decreasing, and sometimes resulting in a value of 0 or even negative. So the next study I want to talk about is a Meyerson study that was done in 1986. It was relatively a big sample study, retrospectively taking a look at, they started with 70 patients, but they ended up with 55 cases from 52 patients, and they looked at different type of treatment that was applied for Lisfranc injury. And what they noticed that, as you can see in the chart, they tried immobilization, closed reduction with internal fixation, and ORIF. And what you can notice is that the Arthrodesis was not initially included in the group, but more of a secondary procedure that was done amongst the patient population here. The key thing to note is that the ORIF and the Arthrodesis had a high painful foot center score system. And for those who are unfamiliar with the painful foot scoring system, it's basically kind of similar to the AOFSA score that people currently use nowadays, where it's a subjective scoring of pain, function, cosmesis, and motion. So painful foot center score has 45 points for pain, 40 points for function, 10 points for cosmesis, and 5 points for motion. So as you can see, the Arthrodesis and the ORIF has a relatively similar value, and this is where people start to realize that, their two treatment plans are somewhat comparable to each other. So kind of open up the gateway to kind of think about the current debate that goes on in podiatry community today, where which one is better. So as an example of a percutaneous closed reduction percutaneous pinning method, as you can see in the picture here, you see the lateral deviation as a metatarsal from 1 through 5 laterally, type A, based on the Hardcastle-Meyerson classification. And you can see that the fixation was done on the right side using 3 pins. And generally you want to keep the pin in for about 6 to 7 weeks, and afterwards on a certain shoe, like a wedge shoe, post-operatively and weight bearing as tolerated. the classical Hardcastle literature also used percutaneous pinning, and as you can see from the picture over here, again, is a type A injury where they are using 2 pins to basically correct the medial and the lateral column. And then the results were okay, to be honest. The impression I got from the literature was that the outcome of the treatment through pinning was mostly based on the type of injury that the patient had. So oftentimes A was 100% of them had a pretty good result, while B and C kind of had a mixed match of fair and poor result. Next type of fixation or treatment plan for Lisfranc is percutaneous and anatomic screw fixation, percutaneous reduction through screw fixation. And the advantage of a percutaneous screw fixation is that you won't cause much of a soft tissue trauma, and that's the advantage. So the research of this paper looked at surgical candidate for this procedure, which they identified as a diastasis more than 2 millimeters between the first metatarsal and the second metatarsal. And they stated that you would put a screw through the medial cuneiform and the first base of the first met, and then the home run screw, which goes from the medial cuneiform to the second metatarsal, and then even to the inner cuneiform joint. They said that if the joint felt unstable, then you could go ahead and put extra screws on the first TMT and the second TMT joint. And then the result was fairly successful. The AOFSA score was relatively high with 94, and patients were pretty satisfied. So the next topic I want to discuss is the primary arthrodesis or ORIF. So like I mentioned earlier, there are literature saying comparable subjective pain scoring between the arthrodesis and ORIF. Mueller did a study where he compared partial arthrodesis with complete arthrodesis, meaning fusing 1 through 5 TMT joint, while partial arthrodesis generally mandated 1 and 2 TMT or third of TMT joint if it seemed unstable, and a fixation through 4 and 5 if was needed. And for an ORIF, kind of similar fashion without the fusing part of the procedure. And in this study, they noted that again the scoring system was generally comparable. The painful score system was close to each other between the partial arthrodesis and ORIF, 75 and 78, respectively, and also noted that the percentage of good to excellent were similar between the partial arthrodesis group and ORIF group. 66% for partial arthrodesis and 68% for ORIF. So, in this literature, kind of created a path where arthrodesis is sometimes worth it or comparable to ORIF versus the complete arthrodesis, which is kind of bad. And if you look at the stats here for the complete, it's not really good. So when we're talking about partial primary arthrodesis for Lisfranc injury, we're talking about partial arthrodesis. The next literature I want to talk about is Coetzee article. It's relatively famous in the orthopedic community. And basically, the article takes a look at 40 patient total, about half and half, 20 and 21, 24 ORIF and 21 for primary arthrodesis. But the special thing about this literature is that the patient population is subtle injury, which they dictated by no major fracture line. The avulsion was included in the patient population, but no major fracture. And they wanted purely ligamentous injury. And what they found out, in the case of purely ligamentous injury, oftentimes ORIF results in 80% of hardware removal. And 5 out of the 80% of the people that got their hardware removed for ORIF procedure had fusion done ultimately. And just overall, the ORIF just resulted in poor pre-injury level and pre-injury activity level, and then the AOFSA score compared to the arthrodesis, which had a much higher AOFSA score and just only 20% of the hardware removal procedure. So another study by Henningsen was kind of similar. Again, the ORIF procedure kind of a decent chunk of it requires patients to go through hardware removal. The stat is very similar to the Coetzee article, as you can see from here. So these are just different articles talking about ORIF and primary arthrodesis, as you can see. And then basically you get a kind of mixed feeling of ORIF and primary arthrodesis, and we're not clear-cut at this point which procedure is better. It's still a debate that goes on whether or not ORIF is better for Lisfranc or primary arthrodesis. So one way that basically you could kind of help figure out the problem for ORIF is basically pain with the removal of hardware or the pain with the hardware. That's why they get it removed 80% of the time. And it's because the injury, the post-traumatic degenerative process that occurs from the injury is the main problem. And some author stated that we could start using dorsal spanning plates, which keeps the articular cartilage intact while providing a rigid fixation, just like any screw would do. So using a dorsal spanning plate was kind of postulated to help kind of minimize the complication with ORIF. And as you see on the picture on the left, that's an example of the dorsal spanning plates. And on the right side, I just put a random 4-corner plate. It can be used for fusion, or I think one of my attendings said that it can be also used for fixation if the injury to the Lisfranc complex is just isolated to the first two metatarsal TMT joints. So another way that you could kind of minimize the complication with ORIF while providing a rigid construct is using a PLA screw, polylactic acid screw, I believe. And this small study was done, 14 patient sample, and Thorsen did it in 2002, where basically did a absorbable screw to fixate ORIF for Lisfranc, and the results were pretty good. As you can see, there's no pain for 2 out of 14 patients, and there's some pain, moderate pain with vigorous activity. So, as long as the patient weren't doing vigorous activity, the screw can work, and a lot of the patient population doesn't do much activity. So these screws generally maintain their tensile strength for their strength grip for 3 months, and they dissolve about 1 year. So they get rid of the complication of hardware removal and get rid of the secondary operations that's needed for a lot of these ORIF patients. So overall, this is just an illustration of algorithm that dictates, kind of guides a physician on how to treat Lisfranc injury depending on the length of the diastasis and also whether it's comminuted or non-comminuted. If it's comminuted, you generally want to fuse it, primary arthrodesis. And also, I read in the literature that if a Lisfranc injury is delayed in its fixation more than 6 weeks, you're better off just fusing it right away. And also remember the Coetzee article where ligamentous injury is better off fusing it too, because oftentimes you will end up fusing it for some of the patients that you do ORIF. So remember that. So subtle injuries that has ligamentous injury, keep in your mind that potentially arthrodesis is going to come along. So this is just summary of the main points of this Lisfranc injury presentation. You want good anatomic reduction and immobilization. Don't underestimate Lisfranc injury. Although the percentage of occurrence is 0.2% of the fracture and dislocation population, 20% of the time at ER it gets misdiagnosed, which is super bad. And you treat Lisfranc injury just like any other trauma. If there's soft tissue swelling, you could kind of wait for the swelling to go down before you take the patient into OR. And also you want rigid fixation immediately using the screw 1 through 3 if you want to fuse it or provide a construct, even ORIF, and never hard fix the 4 or 5. And that's because 4 and 5 have about 10 degrees of motion with the cuboid, so you want to maintain that. Just anatomically speaking, the first 1, 2, and 3 TMT joints don't really have motion. Their range of motion goes about 1 to 3 degrees. So fusing it, that's why fusing is not a really big deal. And after an ORIF, if there's some problem with persistent pain, you start with a conservative treatment of just soft orthosis and stiff sole shoe. But if the pain is progressing and it's not getting better, then you will ultimately do arthrodesis. So that was just about my presentation. And ultimately, what I got from preparing this presentation and talking to attending is that it's really a patient-dependent procedure choice. And you don't want to give patient an option of these choices because we don't, as a physician, don't fully understand what's exactly going on either. So you don't want to give the choice to the patient who can make a misjudgment. And oftentimes, what I got from the attending is that if a patient is compliant and somewhat healthy, then you could definitely go ahead and ORIF with the premise that it can go wrong and you can fixate it. But if the patient has bad comorbidity, bad bone health and all that, joint where secondary procedure might do more harm than good, then you want to go ahead and just fuse it in the first place. So I hope you guys enjoyed this presentation and learned something new about Lisfranc injury, and I really appreciate you guys watching, and tune in for our next video.